People holding hearts before charts, before meds had names, we had compassion. This one's for every nurse, past, present, and future. Let's go.
We are the calm in the storm, the beacon of hope. Every beat, every breath, we honor the oath. From night shifts to day breaks, loving our tone. Pepler taught us, connection heals more than alone. From Florence to futures, we redefine care, not just meds and machines. We're presence of prayer, with hands that comfort, eyes that see truth. Healing ain't a chart, notice what we do. We are nurses with hearts wide open, healing souls in motion.
All right, I think we're recording. Welcome back, everybody, to another episode of Peplow's Ghost. Super excited to have this next guest. Been hanging around with her for a while and meeting her at conferences, and I'm just really looking forward to this conversation, just to get to know her a little bit more. As we all know, it just, we don't have those opportunities to get to hang out with people and just kind of find out what makes them tick. So I am super thrilled to welcome Dr. Elizabeth Hopfenspirger, which again, apologize for the mispronouncing if that is incorrect. Is that right, Elizabeth?
It was spot on. Spot
Awesome.
on, Dan.
Wow.
Yeah.
Jeez. Gold star for me. I can feel it. That's great. So thank you again for being here. And thank you to Dr. Sean Convoy and Dr. Melissa Chapman-Hayes, my other co-hosts here for the podcast. So let's get to it. It's kind of my pleasure to really get to know and ask kind of the history question here and get to, what got you to this place? I know you're the program director for the PMHNP program at the University of Minnesota. You have a lot of experience as an NP, FNP to psych. So you really kind of weave those things together. But, what brought you to this place, as a nurse? What kind of brought you to an NP world and then eventually here as a psych mental health nurse practitioner?
Podcast. I am a longtime fan. My students are longtime listeners. And we center our very first psych-specific course on Hildegard Peplau and her interpersonal relations theory. So this is a dream come true. I love the question you asked me of how I got where I am. And I really love the fact that I am a dual board certified family nurse practitioner and psychiatric nurse practitioner, that I bring both lenses to it. I actually did not practice solo as a family nurse practitioner. I was in the master's program at St. Louis University for family nurse practitioner. And about a month before graduation, I decided I have to do psych. I just have to. All through my rotations, my clinical rotations as a family nurse practitioner, I was in many different settings with family practice physicians, and I saw just a huge gap in being able to help the patients with anything related to mental health, even just nervousness or health anxiety or follow-up. I was following some pretty great providers, but they just didn't address the mental health needs. And then the patient would pull me aside afterward and say, "Can you help me?" And I'd be writing down notes in the hallway, running in between patients. So ultimately, I decided, with the advice of the advisor from St. Louis University, she said, you have to graduate. You can't switch 1 month out from graduation. You have to go on. So I went back to my alma mater, the University of Minnesota, for my DNP for psych mental health. And it is exactly where I needed to be all along. And I look back to, as a kid, I was always interested in what makes people tick, and embracing diversity and asking all kinds of questions, or being able to befriend the new kid or the person who just went through something traumatic. And I've just always been curious about people's stories and forming that therapeutic relationship. So when I look back in hindsight, it was just there all along. And it's the most natural fit to practice in this world. And then a couple of years ago, I made my way into academia. So it's been a really interesting path that I've just kind of followed the cookie crumbs in front of me, or the breadcrumbs through the forest, and it's led me here.
That's so great. I love it. I mean, I think of, I have some similar experiences. Even, when I was getting my RN, I remember going on a cardiovascular floor and there was a patient who was, very clearly depressed, and I wanted to spend all my time with that patient. And my preceptor was like, you're spending too much time with that patient, and really was kind of discouraging of just kind of getting to know this person and just listening to their story. So I knew probably cardiovascular was not my calling, but psych was just kind of more of that fit. And so would you mind kind of continuing your story a little bit? You mentioned, you've been in practice and, found your way to psych, but I think there is this, obviously there is this shortage in academia of, people going into academia and things like that. So you mind sharing a little bit about what made you switch there, going from practice to academia?
Oh, that's great. Great question, because it's a really big shift. I've been practicing for 12 years in the outpatient setting, and I had always created what I always say are really challenging uphill battles for myself, where I would purposefully seek out positions that didn't exist and create them for myself. So, embedded within a primary care setting that has never had a mental health provider, embedded within specialty care settings. And from top to bottom, didn't know what to do with me. So I actually took that as an advantage of, oh, I get to create exactly what I want, how I want it to look. But that in itself, I was practicing solo for most of my career, was very stressful. And I'm all in. I'm very thorough. I was trained in a way where I document very, very fastidiously. I'm actually an expert witness and peer review for legal cases. I'm involved in a case in Arizona right now, so I'm very fastidious about my work. And then for my patients, I have a plan A, B, and C. And as you can imagine, that's a lot. So I decided I wanted a better work-life balance. I know if anyone can figure that out, they're going to be. But one of the big things for me was one of my daughters, when she was entering 6th grade, had a very traumatic health issue where she was diagnosed with Guillain-Barré, and we nurses know what that's like. And she was heading into 6th grade, and during that time, I just really had a deep look inside of what do I want my work-life balance to look like, and my family, and the importance of all that, and how can I fill my own cup while still doing the amazing work that I'm doing. And around that time was when one of my mentors, Dr. Barb Peterson, whom you know very well, Dan, reached out, and it had been in the works, but it became very serious at that time that I was going to make that transition back to my alma mater to teach, as Barb wanted to retire. So I thought, this could give me more work-life balance. I can inspire the next generation of psych NPs, which I loved precepting and teaching and cheerleading along the way. And I thought that would just be a better fit for my life moving forward.
That's perfect. Yeah, that's awesome. I'll be a little timely in the podcast and just make a small joke that I'm hoping that your expert witness is not a part of Lindsay Clancy's case. And I mean, that's the whole thing, right? Everybody's talking about it. It's so hot.
Can't stop. And my specialty is perinatal mental health.
Oh, there you go. There you go.
Very first specialty. So I am not an expert witness in that. I'm very thankful.
Right.
I have a lot to say about it for sure, but no, that is not the case.
That's great. I'm going to turn it over to Sean. Thanks.
Hey, Elizabeth. So I recently read a quote that it was surfaced in my mind when you were talking about your students. And I'm going to ask you another question also about your students in a second. But I'm going to share this quote with you, and then I ask you to kind of respond to it through the lens of being both a psych nurse practitioner, but also a psych nurse practitioner faculty member, okay? And the quote is as follows. In academics, the lesson precedes the test, but in clinical practice, the test commonly precedes the lesson. Can you process this and kind of speak to it?
Oh my God, that's so good. Okay, I know all we nurses know that coming out of our BSN program, we're like, okay, the real learning actually happens on the job. Sean, this is a great question. I know all of us went through RN, got our BSN. We would always hear from faculty and preceptors even, actually learn what you need to know. And I remember being frustrated about that well, can't you prepare me for that? And really, you can't prepare for real world experiences very well. And in the role of faculty, I'm working to change that. So interestingly enough, today is my last day of teaching my brand new summer course, from scratch from my brain and life experiences. It's complex mental health with complex comorbidities. And so I'm using case-based learning for my students based on my patient examples, obviously HIPAA compliant, identifying information, but I specialized in incredibly complex patients, multiple comorbidities. I mean, and my students even said, how in the world did you even do this? Because I wrote them 11 pages. One of them was. And so I'm trying to really immerse them within real world life experiences. And then we talk it through, we hash it out to to show what would it be like when you're dropped right in the deep end instead of the first time when they're there. I want it to be a pre-immersive experience in our courses. So I think the quote that you gave is spot on, but how can we flip that as educators to help them feel prepared, especially in those really complex situations? And then we use that time class to talk up through what would you do, what medications might you prescribe, or what approach would you do? And no answers are bad answers, but then we really see it through all the way to the all have consensus.
That's wonderful. Thank you very much for that. I was also really excited for those of you who weren't listening before Dan turned this on. It was kind of cool because Elizabeth noted that not every school across the country right now actually has a standalone psychotherapy course. So I am super grateful to say that the University of Minnesota is leading from the front in that regard. So Elizabeth, I'm actually going to speak to your students right now. I'm going to say, I would love for you guys to kind of blow up the podcast message boards and identify some memorable things that you learned about Hildegard Peplau and Dr. Elizabeth's course. So Elizabeth, can you just give us a quick, elevator speech about what that psychotherapy course is like?
Well, Sean, we do have a standalone but we also sprinkle psychotherapy throughout very intentionally. So for example, this course that I taught, each module or each week was centered on a very specific intense complex mental health with complex comorbidity. And then the students in each case had to say which psychotherapeutic approach they would take and give a very detailed rationale. And so it was very different, for example, for personnel mental health, sedation, and that is sprinkled throughout many of our courses. The course I was speaking about, where we talk about Hildegard Peplau, is our very first about who came before us, who came past. And our standalone course is different. It's in the fall, and my colleague, Dr. Elena Geiger-Simpson, is teaching that. Psychotherapy, and she has just created this new course for fall centered around colonizing a book. So I'm interested to see what that will look like. So at the Minnesota, we have a lot of integrated within, and then
Thank you very much. I'll pass it to Melissa.
Thank you, Elizabeth. I love hearing about case study examples, especially from your real world practice, and getting that as a sort of bridge between learning in the classroom and preparing them for the real world. So thank you for that. My question's going to flip a little bit to, I'm going to say this word very slowly, psychoneuroendocrinology. I am the non-nurse, so I just want to make sure I pronounce that, and I can't do it fast.
You did great.
Thank you. Your work leans really heavily into psychoneuroendocrinology. How do you bridge the gap between neuroendocrine pathways like HPA axis dysfunction or hormonal dysregulation and the lived emotional experiences of your patients? What does that look like?
Oh, that's amazing. I'm going to first talk about it from my approach as a clinician, and then I want to talk a little bit about my approach as an educator. So with that is into this, kind of like the breadcrumbs through the forest. Everything kind of just falls before me and I follow it. I was seeing a lot of really, really ultra sensitive women in the perimenopausal, menopausal range. And then with my specialty in perinatal mental health, I would get a lot of those patients. So naturally, they'd want to know, what is going on with me? Why is this happening? Is there anything I can do to prevent it? And so going down into the pathophysiology of that in a very thoughtful, user-friendly way of why this might be happening was really empowering for that. And I don't want to just all women, men too. I would see men with lower testosterone or all of these life changes. But really is, what is our body and our brain doing during times of transition? And that is not talked about enough. It's not studied enough. And it's just happening. And this generation of women in perimenopause right now, I've noticed, want answers. They want help. They're starting the conversation. And so it's ripe for the taking. And they want to know what is going on. And I work one day a week in a precision medicine clinic where we take individual clients and we look at everything, their labs, their life history, their surgeries, their trauma, their everything, and kind of go deep So really it started with questions from my patients of what is going on. And so I wanted to know what's going on a neurotransmitter level. You know, when estrogen decreases, our serotonin and our dopamine decrease. Well, when our dopamine decreases, what's that doing to women with ADHD in midlife? They're really struggling. And so then does that set the nervous system on fight or flight mode? And then how does that feedback loop continue? So it really started with all of those questions. And then, well, what are some of our answers to all of those areas? I found that with my patients, just having some answer of what's going on and why, a lot of them felt like they were crazy. So knowing, you know what, I think I know why this might be happening. Here are some thoughts on that. And here's some things that we can try to help your nervous system calm down, to help get back into the parasympathetic, to help rebalance some of those hormones. They felt empowered, at least having some knowledge. And now translating that to my students in this course this summer, there was a whole section on care across the menstrual cycle, perinatal mental health, menopause and perimenopause, and what we do, how we assess, how we talk to these people about that, and what's some of our treatment options. So I feel like I just kind of word vomited, but did that answer your question?
Yeah, I thought
Okay.
especially the perimenopause or low testosterone, then taking that holistic lens of like, I guess, first of all, creating a space so people can ask questions and look at their life holistically, biologically, psychologically, the trauma, and figure out what's going on. I mean, that's empowering in and of itself. Thank you.
Very.
Yeah, I'll pass it back to him.
And then, yeah, thank you. It's a great question. Thank you.
Yeah, I mean, I think maybe kind of just continuing on that kind of line of thinking, this is a question that I don't know why we haven't asked others, because obviously we've had other guests on here who have been duly certified like yourself with FNP and psych, but I think you, in your role as in academia and all your experience that you've had, how do you differentiate, the way that we prescribe psychotropic medications in primary care versus psychiatry? I mean, what is the difference? I have a colleague who tells me, we get a lot of what we call post-grad cert students who are coming back and getting recertified. And they basically say, this is not a program just to learn how to prescribe Seroquel. So that's not it. So what else, goes into prescribing, from a psych mental health nurse practitioner role that they don't get in the primary care and things like that? Or how do you see the difference because everybody prescribes, Prozac or Lexapro. I mean, that's not an art, but what kind of differentiates that for you?
I think it's all in the comfort level of the provider and how stressful that they anticipate it to be. So I would do a lot of this with my last position that I worked in, where I was embedded within a primary care setting with specialty providers, 50 primary care providers, and they would come to me before they saw a patient, and they'd see the patient on their schedule and say, oh, this is a postpartum depression patient. What should I do? And I go, well, have you seen them yet? And they go, no, I haven't. I'm like, what? Oh, see them first and approach them as a human. So I'd say, this is a human. We're talking to a human being. You are also a human being. You have that in common. That's a good place to start. And ask questions. Be genuinely curious and allow them that chance to answer it without fear of being judged. And that alone would just kind of take the temperature and the pressure in the room down. And I'd say, ask them basic things like, how was their sleep? How is their appetite? Are they enjoying things they used to enjoy? And so I think it really is a nervousness about, oh my God, what do I do? What if they need Clozaril or something like that? And really, it's never as bad as they anticipated it would be. And I'd say, if it's out of your comfort zone, come ask me. I'm happy to walk you through this, or I'm happy to see the patient, but I prefer to educate them on, here are some of your options. And what do you think would be the best way to do it? So it was a good way to educate primary care. And many of them felt very empowered. I still have them messaging me to this day, and I haven't worked there in 2 years, of, I'm thinking of doing this with this patient. What do you think? So I really think it's just a nervousness and a fear of, okay, if I ask a question and it brings something up that I don't know what to do, then what? So it's knowing your resources, really.
Yeah, I'd love to speak to them about that anxiety. That's I've seen that many times too, where I've had somebody says, if I'm going to ask a patient about suicide, I want a psych person right on my hip because and it's the anxiety of what if they say yes? What do I do with that patient then? And so that's a great answer. So thank you, Sean.
Hey, friend. So when I say this, I don't believe that I'm hallucinating, but I believe that when when we have these podcasts, Dr. Peplau is kind of speaking to me. Well, that's not accurate. She's not speaking to me. She typically declares more. So today she's declaring and she's saying, Convoy, get back to psychotherapy. So I'm going to ask another question about psychotherapy, right? So can you share a few practical examples of how you are preparing your students to develop greater insight into their own countertransference without shame?
Oh, Sean, this is an amazing question. I love it. We start this from the nanosecond they are in our classroom. We talk about reflective practice from that very second. And this is, I think, one of the strengths of our program is our reflective practice and how we set the tone for that, for our students to reflect and receive feedback. So we give a lot of lead-in time of what is reflective practice and what does it look like. It's not just Dear Diary, today was whatever. And then giving and receiving feedback. A lot of people receiving feedback, we know, don't take it well, or their hackles go up. So it really is both reflective practice and receiving feedback. And we tee that up so beautifully. And I'm just thinking of my students that just are finishing their course today, seeing their reflective practice. And we require reflective practice in each of our courses. Reflective journals, whether it's typed or audio or through some art medium. And we just get to see the trajectory of that over the course of their program and how deep they go in, how much they examine countertransference and transference and their biases. And we talk about that in class too, when we start to do case studies in class. And I will lovingly say to a student, you know what, I think I'm noticing some countertransference here. What do you think about that? What is this patient bringing up in you? Or maybe sidebar, obviously not calling them out in front of their peers, but having read their journals and knowing their history of, okay, I see this coming up, knowing your background, knowing what went on in your childhood and the way you're responding to this patient now. So we talk a lot about that, and our students are really teed up for receiving that feedback because they know it's coming from a place of deep love and respect for them as humans.
Thank you so very much. I appreciate that. I'll share one of the strategies that I've kind of developed over the years to target this is that I remind all of our Psych NP students that in the physician training pipeline, 1 year of their psychiatry residency, those psychiatric trainees are learning how to, they get a year of psychotherapy themselves to learn how to separate their stuff from their patient stuff. So we do not have the luxury of time to mandate that within advanced practice nursing. But what I do is, in our practicum courses for hours, we have direct hours, which ANCC or AANP requires, a minimum of 500 today. God knows what it's going to be tomorrow. And then we have some additional hours of indirect hours. And I always encourage students, I say, you can acquire your indirect hours by getting individual psychotherapy to learn how to separate your stuff from your patient stuff. So I appreciate your approaches here. And I would encourage everybody who's out there who wants to be a Psych NP or is a Psych NP to recognize that you're the biggest cynic in the world if you don't think you could benefit from that which you provide, which means we all probably need our own psychotherapy at some point in time.
I love that. We bring that up to our students as well. And I had a student, I happened to be precepting one of my students we have our students in a free neighborhood clinic in the evenings providing psych services. And she said to me, she goes, you know what? With all the things we've talked about in this class, I decided to start therapy for the very first time in my life. She said, I didn't think that I needed it, but we also openly talk about things that we might be working on in therapy, not oversharing or whatever, but just interesting things that might come up. And it really inspired her to say, you know what, I really could benefit from seeing a therapist. And she did. And there was a lot of stigma in her family about that, but she was really happy to say that she saw the benefit in that too.
Fantastic. Thanks. I'll pass it to Melissa.
Thank you. So looking at the future of integrated healthcare, what advice would you give to FNPs and PMHNPs who want to deepen their understanding of psychoneuroendocrinology? while keeping the human connection at the center of practice?
It all comes down to curiosity, just embracing that curiosity. I don't surround myself very often with people that aren't curious. So it always boggles my mind of those who are not. So it's just embracing that curiosity and then being aware of what your patients are looking for and who's coming to see you. So a lot of kind of the rabbit trails that I've gone down or the deep dives have come from my own patients of, can you help me with this or what's going on? And I think, well, I can't really find much information on it. I'm going to start looking into it. So using that as a barometer for what people are wanting and seeing and using that to inform your own practice. Because you're going to learn a whole lot, and that's never a bad thing. Being a lifelong learner is good for us in so many ways. But knowing what our patients are wanting to know, what they're coming to us with, and then maintaining that really genuine, deep curiosity, I think is the biggest thing that I can say for that answer.
One thing that I meant to say earlier is when you've said during this podcast that you've followed breadcrumbs or cookie crumbs through the forest, I just wanted to elevate that you also noticed that there were breadcrumbs to follow and then did that, which I don't, I just wanted to kind of elevate that step in it as well.
That's true. And well, I think it comes up for a lot of us, but we just are, head down, plowing through the day, getting through the day, not noticing. And I know my therapist, he always says to me, and I can hear it in my head, Sean, I know you said you were hearing voices from Peplau. I hear voices from my therapist saying, just notice. So when I just notice, and I think we all have it in ourselves, but it's just, are we taking that time and having that mental space to actually see, oh my gosh, what is unfolding before me? Somehow I have that gift where I'm just not head down plowing through. I'm noticing some of these things coming up.
The voice in my head is the power of the pause, the power of the pause, Melissa, the power of the pause, pause, right?
Very true. Very, very true. Well, this is great, and I got a little goosebumps there. So thank you, Elizabeth, for that last response. That's amazing. What we do right now is I'm going to have our previous guest, Dr. Josh Waddle. He's got a question for Dr. Elizabeth here, so I'm going to cue that up real quick, and we'll see your response on the other side here.
Thank you, Dr. Elizabeth. Your role as a director in the PMHNP space, I would love to know, where do you see the education of PMHNPs going in the next 5 years? There's a lot of questions on hybrid and virtual and in-person. What do you see needs to be the consistent factor in these educations to ensure we're producing good providers for health?
Awesome. Thanks, Josh. Appreciate it. We'll look for that answer. Awesome.
Okay.
All right. What do you think?
That is an amazing question. I feel like I've said that with every prompt that you guys give me. You're keeping me on my toes here. What I think needs to happen is still that in-person learning. So the online programs, especially in psych mental health, I mean, come on, we need that in-person learning. A lot of our jobs, I mean, even for telehealth only, we need to know how to read people, how to get the feelings and the vibes and the nonverbals and that connection piece and that felt sense. We need that. And two, with our jobs, this is a very stressful field to be in. I love it. I can't imagine anything else, but we need that camaraderie and that support. And it really doesn't compare when you're doing it online versus in person. So I really think at minimum, education programs need to be hybrid. They just do. We do a hybrid program where we meet at least once a month in person. And it really is flexible for students, but they really value that in-person time. And what I hear them say is, we wish we could meet in person more. And so I really think that face-to-face in-person time where you can feel the feels in the room, that's important. So I think that is really key. And is that feasible for everybody? No, but I don't think it should be normalized that everything should be a telehealth and you quick check boxes and you meet in person for one day out of the whole 3-year program. I don't think that that's appropriate, especially for psych mental health. And then I want to say too, we need to start educating our students, if we haven't already, on the really, really complex mental health presentations, because primary care is catching a lot of these bread and butters, so to speak. And I would always love when I had someone that would come to me with, it was just depression or just anxiety. And I go, oh my gosh, it's like Christmas morning. I love all my patients, but we need to set the expectation for our students that, primary care is going to catch a lot of those we're going to be seeing the really complex presentations. So we need to up our game in terms of educating and being mentally prepared for that scenario.
Wonderful way to end this podcast. And I will just share as well. I know this is an audio podcast, but you can't see Sean and Melissa are just kind of jumping and doing cartwheels here with your responses. So I think we're all kind of in agreement. And again, just like I love to say with this podcast, just a friendly conversation among friends. So thank you, Dr. Elizabeth Hopfenspirger. It's always such a risky thing, but thank you very much, Elizabeth, for being here. And thank you for listening. Appreciate it. Look for another episode coming out soon. Please feel free to like, subscribe, send comments. Like we've said before, have a thought for another guest, let us know. We'd love to have them on. So, all right, until next time.
Carrying the torch through the blood and the rain. We are nurses, the world can't forget. We give our all, no regrets. Modern in our ways, but our roots don't decay. Nurses anthem and it's here to stay. We are nurses.
So here's to the hands that heal, the hearts that stay steady, the voices that whisper you're not alone. Because nursing isn't just what we do, it's who we are.